Practical pathology of small intestine, colon, and rectum. The first specimen would be the gross picture of acute suppurative appendicitis complicated with gangrene, as we have two pictures of the jar for this specimen. To look closer for the jar, it shows an enlarged appendix with a dull smooth surface, showing alternating areas of blackish streaks for the gangrene together with yellowish areas of suppuration. Before we go for the second specimen, which is the microscopic picture of acute suppurative appendicitis, here we have a microscopic transverse section in the appendix. It shows the appendicular wall, which is formed of multiple layers. The mucosa, which is the innermost layer. Underneath it, there is the submucosa full of the reactive lymphoid follicles, then the muscularis propria, which is the muscle layer, and lastly the serosa. The second specimen, which is the microscopic picture of acute suppurative appendicitis, we have here a transverse section in the appendicular wall. It shows the lumen full of the partially shedded mucosa because of the inflammation, and the wall, which is formed of the four layers we mentioned before: mucosa, submucosa, muscle layer, and serosa, all showing dilated congested capillaries and cellular infiltrate of acute inflammatory cells like neutrophils, pus cells, and macrophages. The third specimen is called the gross picture of intestinal intussusception. As we know, intussusception is a serious condition of intestinal obstruction in which part of the intestine slides in or goes in another part of the intestine. It may occur in the ileocecal area, thus called the ileocecal intussusception, or may occur in the colon, thus called colocolic intussusception. As we have here, the intussusception area is formed of the part which goes in or slides in is called the intussusceptum here on the right, and the part which receives the other part, which is called the intussuscipiens. Again, we have here the gross picture of intestinal intussusception formed of the intussusceptum part and the intussuscipiens part. As it's a form of intestinal obstruction, we see here the wall of the intussusceptum and the intussuscipiens are congested because of the intestinal obstruction. Next, we have the Meckel's diverticulum. Meckel's diverticulum is a true diverticulum being congenital since birth. Occurs as a blind-ended pouch, as we have here, arising from the anti-mesenteric side of the small intestinal wall as a vestigial remnant of the omphallomesenteric duct, or called the vitelline duct. It's attached to the anterior abdominal wall by a fibrous cord. It involves 3 layers of the intestinal wall, so it's called a true diverticulum, not just outpouching of the mucosa or 1 layer. It's formed of 3 layers or the 4 layers of the intestinal wall. The complications of the Meckel's diverticulum involves the volvulus or intestinal obstruction, and it may contain ectopic gastric tissue. Our specimen is the gross picture of the Meckel's diverticulum. As we see here, this is a blind-ended pouch of the small intestinal wall. It's called the Meckel's diverticulum. It arises from the anti-mesenteric side of the small intestinal wall. Anti-mesenteric side is the other side opposite to the mesentery. As we have seen before, the true diverticulum, which is the Meckel's diverticulum, we have here the acquired diverticular disease or diverticulosis. It's an acquired disease. It occurs in old age, mostly in sigmoid colon, because of weakness of the intestinal wall. Colonic diverticuli are thin outpouching of the wall, mostly formed of mucosa and submucosa with an attenuated or almost absent muscle layer. The adjacent part of the large bowel wall would be formed of prominent hypertrophy and thickening of the muscularis propria. The specimen we have is the gross picture of diverticular disease. We have here a part of the large bowel or the colon formed of colonic wall, showing this is the tinea coli, which is normal, and multiple outpouching or diverticuli, which is the diverticular disease. It's seen from outside. Another example for the gross picture of diverticular disease, we have here section in part of the colon showing multiple outpouching or the diverticuli, which are formed, as we mentioned, of mucosa, submucosa, and markedly attenuated muscle layer. The adjacent part of the large bowel wall would be formed of hypertrophied or thickened muscle layer. The next specimen is the gross picture or jar for cancer colon fungating mass. We have here a loop of the large intestine showing a single grayish white fungating cauliflower mass. It has a friable necrotic surface and it projects into the lumen. As we see, the loop of the large intestine shows narrowing at the area of the mass and it is dilated above the area of the mass. As we see the other surface of the loop of the large intestine, it shows here appendices epiploici, which are normal for the loop of the large intestine. Another pattern for the gross picture of cancer colon, which is the ulcerative mass or the malignant ulcer. We have here a loop of the large intestine showing a malignant ulcer or ulcerative mass, the pinkish one here, having a raised everted edge and necrotic friable floor and fixed indurated base. The last pattern for the gross picture of cancer colon is the infiltrative mass. As we have here a loop of the large intestine showing infiltration of the wall of the loop by malignant tumor mass. It causes thickening of the wall of the loop. As we see here, this is the tumor, causing narrowing of the lumen, while the other part of the loop has normal area. Last specimen we have is the microscopic picture of colorectal adenocarcinoma. We have here a transverse microscopic section in the colon showing the mucosa and submucosa infiltrated by the malignant acini. They are here variable in size and fused together in some areas. They are lined by one or more layer of malignant cells. The malignant cells, as we would see next, are very pleomorphic, having hyperchromatic nuclei with high nucleocytoplasmic ratio. Here is another example for the microscopic picture of colorectal adenocarcinoma. These are the malignant acini. They are variable in size and shape. Some are fused together like here. The lining of the acini is formed of malignant cells, very pleomorphic cells with hyperchromatic nuclei and showing high nucleocytoplasmic ratio. This is our last specimen, and thank you.